method is the director of Institute of Immunology, teacher and trainer for postdoctoral radiology and phytomedicine program. And he will present the topic simplifying complex heterotaxy.
Okay. Thank you very much, and thank you for that considerable kind introduction. And I would like to thank the SAM for giving me this opportunity to participate in this SAM 2026. Now, today's section being cardiac evaluation made easy. I think in the post-lunch period, making cardiac lesions made easy is not that easy. And one of the complicated things that we come across is the heterotaxy. And quite often, I'll try my best to make it as easy as possible for you to go back on Monday and try to evaluate these lesions. And wherever you get, there are certain tips that I would like to give you so that they can lead you to suspect and diagnose certain various heterotaxies. Now, when we talk about the heterotaxis, basically we are dealing with the jumbled organs and genetic association. Now, this topic, that is the heterotaxy, is a very interesting but intricate, but at the same time it is complex topic. It is a combination of maldevelopment, malalignment as well as genetics. Now today's my presentation will basically be three components. One is the embryology and development and arrangement of these structures. That is basically about the organization of these structures. Associated abnormalities with these jumbled organs as well as genetic association. Now, key factor to diagnose heterotaxy is basically ultrasound as well as genetics. This is one thing which we have to keep in mind. When we consider these jumbled organs, there are various differential diagnoses ones we have to keep in mind. These are the things that we clinically come across whenever we evaluate these jumbled organs. One of them, and the commonest one, being the heterotaxy syndrome. Then we have the congenital diaphragmatic hernias and malrotations. These are the three components that will result in jumbled organs. Basically, these are all basically because of the maldevelopment, malalignment as well as the associated syndromes. And this can be associated with chromosomal abnormalities or genetic syndromes or environmental factors. And the evaluation is basically by what's called as the whole exome sequencing or copy number variation sequencing. So these are the factors that we have to consider while evaluating these jumbled organs or the heterotaxy. Now, coming to the basic understanding of embryological development, we all know that the abdominal organs are non-paired because we have only one liver, we have one stomach, we have one spleen, we have one aorta as well as one inferior vena cava. Whereas the thoracic structures are always paired. So this is one understanding that we need to get very clear about, which will help us in understanding the maldevelopment and malalignment of these structures. When you talk about the embryological development of these structures, it follows what's called as the spatially controlled coordinated pattern. Now, whenever there is a misappropriation of this, or it leads to a well-defined right-sided structures to be on the right side, left-sided structures to be on the left side. This is one thing that we have to understand very clearly. Now, when we talk about the spatial relationship, it is either a situs solitus or situs inversus or situs ambiguous, which is nothing but the heterotaxy syndrome. Now, when we talk about the situs solitus, we need to understand that all the right-sided structures are on the right side, left-sided structures are on the left side. That means the liver, IBC, SVC, right atrium, right atrial appendage, trilobe lung, and epicardial bronchus are on the right side, whereas the stomach, spleen, pulmonary valves, pulmonary veins, as well as the left atrium and left atrial appendage, bilobe lung, as well as the hypoarterial bronchus is on the left side. So this sort of a normal arrangement has to be followed in order to call this as a heterotaxy or in the situs solitus. Now, whenever there is a switch or a mirror image arrangement of these visceral and thoracic structures, other than the situs solitus, then we call it as situs inversus. The reason is very clear that from the beginning of our evaluation of the fetal heart, we basically follow what's called as the sequential segmental evaluation, where we start from the upper abdomen, that is the upper abdomen of the fetus, wherein we need to understand that the relationship or the correlation between the apex of the heart and the stomach has to be established. Once that is established, and if the apex of the heart is on the left side and the stomach is on the left side, we know that we are dealing with situs solidus if we have already identified the laterality of the fetus. If it is the other way around, where the established laterality has shown that the stomach is on the right side and the apex of the heart is on the right side, we call it as situs inversus. The reason we need to establish this is because the situs solidus as well as the situs inversus, the associated cardiac abnormalities are not that common. That is the reason why we need to establish this. Whereas in a situs ambiguous, there in this one, the visceral as well as thoracic organs are arranged in any other fashion other than the situs solidus or situs inversus. That means the stomach is on to the left side, the apex of the heart is on to the right side. The apex of the heart is on to the left side and the stomach is on to the right side. That exactly gives you what is called as the first section itself tells you that there is something wrong with the arrangement or alignment, which prompts you to think in terms of a causal heterotaxy. Now, whenever we think about this thing, whenever we have this sort of a correlation, then we call it as a situs ambiguous, or it's also known as unknown situs or complex situs. And this situs ambiguous is usually associated with various cardiac and extracardiac abnormalities. This is the basic concept that we need to understand. Now, let us get to the heterotaxy syndrome. Now, heterotaxy is nothing but different arrangement. In visceral heterotaxy, as we have abdominal organs which are non-paired, they become irregularly arranged and there will be an irregular arrangement of the non-paired structures. Whereas the isomerism or the thoracic organs, which are normally symmetrically arranged, otherwise they become symmetrically arranged, which are otherwise asymmetrically arranged. So whenever we have a paired organs which are arranged in an asymmetric fashion, or whenever we have an irregular arrangement of non-paired organs, that is when you start suspecting the possibility of heterotaxy. Basically, the classification depends upon bilateral left-sidedness, that is what is called as the left isomerism, and bilateral right-sidedness, which is called as the right-sided isomerism. Now, with this basic background, let us try to understand what is this left-sided isomerism. When I say left-sided isomerism, it is bilateral left-sidedness, more of left-sided structures. That means the left-sided viscera will be paired with the absence of the right-sided viscera. That means there will be left atrium and the left atrial appendage on either sides, so that it replaces the right atrium. The right atrium has got the SA bone, which is the conducting factor. That is the conduction is done by the atrioventricular conduction is started there. So absence of that, it results in the arrhythmias. So that is one of the most important things that we know. So absent right atrium results in cardiac arrhythmias. Not only that, because of the left-sidedness, the imperial vena cava, which is on the right side, will be absent, but the distal systemic venous return is taken over by the azygos continuation. That is, the azygos opens up and tries to drain the distal systemic venous circulation into the right atrium. So it will be interrupted IVC with azygos continuation. That is true. Next important factor is that these heterotaxies are usually associated, as I said, they are associated with multiple cardiac abnormalities such as the AVSDs or pulmonary stenosis. And another thing is that bilateral morphological left lung and multiple spinoons and interstitial malrotations. These are all the associated factors that we need to consider. So, if you have to identify a left isomerism, basically there are two most important factors that you need to keep in mind while evaluating. One is cardiac arrhythmias, second is interrupted IVC and azygos continuation. If you can establish this, yes, definitely you can make out the possibility of a left isomerism. That is as far as the left isomerism is concerned. Then comes the right isomerism, in which the right side, more of right-sidedness, that is bilateral right-sidedness, where the right-sided structures are paired and then the absence of left-sided structures. So there will be what is called as the bilateral right atrial appendages, because appendages, to identify appendages is very difficult. But then in place of possibility that we have that the right atrial appendage is usually pyramidal shaped or rounded, whereas the left atrial appendage is sickle shaped or the finger shaped structure. This right atrial isomerism is usually associated with multiple cardiac abnormalities such as the AVSTs and abnormal venous drainages. So these isomerisms are associated with certain abnormal veins. In a left isomerism, it is the inferior vena cava which is interrupted, whereas in the right isomerism, it is the TAPC, that is the coronary veins opening into the left atrium becomes abnormal. So these are the two associated things that we have to keep in mind, and there will be bilateral morphological right lung as well as absent spleen. So these are all the factors. So to conclude, in sense, the right isomerism, basically we have complex cardiac abnormalities, juxtaposed aorta as per as the inferior vena cava, anomalous pulmonary venous drainage are the three most important factors that we need to consider in order to identify a right isomerism. Now, next comes the incidence. Incidence is about almost 1 in 10,000 live births. The recurrence rate is only 10%. Right isomerism is much more common than the left isomerism. Basically, because most of the left isomerisms cannot progress during pregnancy because of conduction defects results in congestive cardiac failure that results in fetal demise. Quite often heterotaxy is sporadic, and about 10% of them are associated with genetic mutations, and the genes that are associated are GIG3, whereas the left atrial tick and ACVST. These are the various genes that are associated with it. Rarely the heterotaxy syndrome can be familial. So this is one thing that we have to keep in mind. Now, predated diagnosis. How are we going to diagnose tomorrow on Monday when you go back and start working? We need to understand what are the factors that you are going to consider before you label a fetus as having a heterotaxy. There are 4 factors that we need to consider. First and foremost thing is there will be ambiguous situs. That is one thing which you have to establish. That is one. Second is presence of complex cardiac abnormality. Third is whether there is any complete heart block or any arrhythmias, cardiac arrhythmias. Fourth is any veno-atrial connection abnormality. That is either a azygos is draining into the right atrium, or the pulmonary veins are not opening directly into the left atrium. So these are the factors, 4 factors, which will tell you that you are dealing with the heterotaxy. Now, this is a simple way of identifying is that when you start evaluating, as I said, the first section which you are going to take is the upper abdomen of the fetus. In the upper abdomen of the fetus, normally you know that you can see that the aorta is onto the left of the vertebral body, as well as the inferior vena cava is to the right and anterior to the aorta. Whereas in a situs inversus, it will just be a mirror image. But whereas in a left atrial isomerism, there will be juxtaposed or the double barrel appearance, because the inferior vena cava is interrupted. The systemic venous drainage from the lower limbs are taken up by the azygos continuity. So you find 2 rounded structures adjacent on either side of the vertebral body, one being the aorta, the other being the inferior vena cava, which is not actually the inferior vena cava but the azygos vein, because inferior vena cava is always to the right and anterior of the aorta. Whereas in the right atrial isomerism, what happens is there will be juxtaposed. So the inferior vena cava as well as the aorta will be on the same side. So this is the one which starts you putting into guard, that is, it alerts you that you are dealing with a complex cardiac abnormality, that is particularly a heterotaxy. Now, predated diagnosis of left atrial isomerism, first and foremost thing, there will be situs ambiguous. We all know what is situs ambiguous, and we know very easily to diagnose situs ambiguous. Then we have 2 morphological left atrial appendages. Now, what is left atrial appendage? How do you identify? It is usually a sickle-shaped or a finger-shaped structure. That is one. Second thing is there will be double barrel sign or interrupter IVC, which will be taken over by the azygos continuation, so that aorta and the azygos will be adjacent to each other. That gives you what is called as the double barrel sign. The third one is they will definitely be associated with complex cardiac abnormalities, and as the right atrium is replaced by the left atrium, there will be a SA node absence that results in cardiac arrhythmias. So these are the factors which will tell you so that you are dealing with the left atrial isomerism. Now, this is a classical case where we have a sickle-shaped left atrial appendage in the left atrial isomerism. in which the right atrium has been replaced by the left atrium. We have a complex cardiac abnormality. If you carefully see that, you can see that there are two structures, rounded structures in the prevertebral region. One is the aorta, the other one is the azygos continuation. So there are three factors which have been established. First and foremost thing is that there is a azygos continuation. Second one is there is an atrial appendage which is left atrial appendage. Third one is that there is a cardiac abnormality. So that is a complex cardiac abnormality. Now this is a classical appearance of a double barrel sign where you can see that the aorta and the inferior vena cava are adjacent to one another, and at the same time they are of the same caliber, and as you can see in the sagittal section also, you can see the flow across, one from the downward flow and the other one is the upward flow, where the azygos drains this the lower limb venous circulation into the right atrium. So these are the various factors that we have to consider. Now this is again a classical case of interrupted IVC, plus at the same time you have a complex cardiac abnormality, and not only that, you have actually the atrioventricular dissociation also associated with this with a double barrel sign, which is very, very typical of associated cardiac abnormalities which are there with left isomerism. Now this is another case where you can even do the upper mediastinum. There you can see the right atrium, that is the Hammocks sign, which you have to normally see, where you can see the superior vena cava nicely opening into the right atrium, whereas the inferior vena cava is not seen at all. So this again confirms the interruption of the inferior vena cava. Now this is also can be, as I said, the SA node is being absent, there will be cardiac arrhythmias, where you can see that there is every atrial contraction is not conducted into the ventricle. So that is, there is an atrioventricular discordance, that is the atrioventricular dissociation, where the signals which are electrical signals, which are impulses that are sent by the atria are not conducted into the ventricle, which results in cardiac arrhythmias, or also a complete heart block, which will in turn result in cardiac congestive cardiac failures. Now, even in the first trimester also, you can start suspecting, as you can see in this particular case, where you can find that you can see the effects of the heart and then the stomach are on opposite sides. That itself tells you that there is a possibility of heterotaxy, or the site is ambiguous. And here you have a complex cardiac abnormality. As you can see here, there is an atrioventricular septal defect. Associated with it, you have two the vessels which are just in front of the aorta, which can be identified as early as 13.3 weeks of gestation. So quite often you can even identify very early in our examination of these first trimester pieces also. Now coming to the prenatal diagnosis of right isomerism, as I said, it is again associated with the site is ambiguous. Two morphological right atrial appendages, that means there will be a pyramidal shaped or a dome shaped appendages, blunt appendages, and then there will be juxtaposition of the aorta as well as the inferior vena cava. So when you do the upper abdominal section, you find that both the aorta and the inferior vena cava are on the same side and are usually adjacent to one another, which prompts you to think in terms of wherein in the left isomerism you have two adjacent structures, which are one is the left-sided aorta, the other one is the right-sided azygos. Whereas here, the inferior vena cava as well as the aorta will be one above the other or on the same side, that is one. There will be complex cardiac abnormalities associated with atriovenous abnormalities such as the pulmonary venous drainage, abnormal pulmonary venous drainage. So these are the factors that we have to keep in mind when we are dealing with the right isomerism. Here, you have a classical case where you have a dome-shaped right atrial appendage, and in this we can also find that there is a twin sign, which you can see find that there is the left pulmonary veins are not directly opening into the left atrium, but they are joining together to form a channel which will open into the right atrium, as you can see here also. And associated with it, there is a gross atrioventricular septal defect, and you can also see that the area behind the heart is increased. So these are the factors which will tell you that there is the possibility of a right isomerism. Similarly, you can find another factor is that this is the place where you can see both the twigs or the pulmonary veins are not directly opening into the left atrium, but they are opening into a channel, which in turn will be opening into the left atrium. and it is definitely associated with complex cardiac abnormalities. As you can see, one of the commonest is being the atrioventricular septal defects associated with the TAPVC, that is the total anomalous pulmonary venous drainage. Now, this can also be associated with a certain atrioventricular and ventricular arterial discordance, wherein you can see that here we have a large ventricular septal defect. You find that the left atrium is not opening directly, and not only that, you can also see that the factor is that you can find that these are the vessels which are arising from the left atrium and the right ventricle. That is the left atrium which is opening into the right ventricle, and that is the atrioventricular discordance. And then again we have a concordance of the ventricular arterial concordance. Associated with it, you can see the TAPVC, which is very, very typical of a isomerism. Not only that, there is what's called as the stomach distance ratio, wherein the stomach becomes much more closer to the abdominal aorta, as well as here you can see nicely juxtaposed aorta as well as the inferior vena cava, one adjacent to the other. So, diagnosis of isomerism is made in the presence and combination of at least two factors. We all know in a left atrial isomerism, we definitely know that the left atrium is in abundance. So the right atrial structures are not there. So there will be cardiac arrhythmias and interrupted IVC. These are the two factors which will prompt us to think in terms of isomerism. Whereas in the right atrial isomerism, there is more of right-sidedness. There will be what is called as the juxtaposed abdominal aorta as well as the inferior vena cava, complex cardiac abnormalities associated with there will be TAPVC. So these are the factors that will prompt us to diagnose heterotaxy. Now associated are the visceral abnormalities, because this left atrial isomerism can be associated with malrotations and malformations or fixations of the bowel, gastric volvulus, esophageal hiatus hernias, biliary atresia, and right-sided isomerism basically becomes because there will be asplenia, they are much more prone to infections. Now, prognostication, definitely we need to prognosticate them because we need to understand the postnatal periods also. Particularly, most of the left atrial isomerisms are not prone to have fetal demise early in the gestation, whereas the right atrial isomerism can progress, but then they are also associated with complex cardiac abnormalities with a bad prognostication. Associated visceral abnormalities are the ones which will actually dictate our counseling of these patients. Now, these are the key messages, that is the key factors that you need to keep in mind. First and foremost thing, the characteristics which you are going to consider in identifying the left and right isomerisms are: one, atrial appendages. On the right atrial isomerism, you have two left atrial appendages. Right atrial isomerism, you have two right atrial appendages. Multiple cardiac abnormalities are present in both. Congenital heart block is seen only in the left atrial isomerism, not in the right atrial isomerism. Pulmonary bilobed lungs are on the left atrium, left isomerism, or the right isomerism has got bilateral trilobed lungs. Polysphenia is present in left-sided, not present in the right-sided right atrial isomerism. Venous abnormalities in left isomerism, what we have is interrupted IVC and azygos continuation, whereas in right isomerism, we have total anomalous pulmonary venous drainage. So these are the factors that we have to keep in mind. And to make it much more simple and algorithmic approach, we have first and foremost thing identified as situs ambiguous. Once we have identified the situs ambiguous, just look for the veno-atrial connections. If it is also associated with complex cardiac abnormalities and there is an abnormal veno-atrial connection, such as absent inferior vena cava and azygos continuation, in that situation, we are dealing with left isomerism. If there is an abnormal veno-atrial connection where there is a pulmonary veins which are not opening into the left atrium, not only that there are juxtaposed aorta and inferior vena cava, we are dealing with right isomerism. And in left isomerism, not only this, but also we will find a factor that there will be a fetal bradycardia or conduction defects. And if there is the veno-atrial connections are normal, then we are dealing with something which is other than the heterotaxy. So this is to summarize the algorithmic approach of making heterotaxy diagnosis as simple as possible. Thank you very, very much.